Thanks, Megan, and thanks, colleagues, for an excellent session. And also thanks to all the presenters for today, really high quality presentations. I think the session's been fantastic. My job really is to bring together some discussion and a bit of an overview of some of the key messages I think have come across today. But also I'm going to encourage my colleagues to put on the cameras in a second, the backroom team that have been working hard, and to also hear their perspectives from what we've heard today. And if anybody has got any other questions or views they want to pop into Q&A, then we'll try our best to get through those. So in terms of key themes across the sessions, well, what we did see was that COVID did and continues to disrupt models of care, but it has provided opportunities to change and test new models. I think the presentations highlighted the agility of our health research community to respond to the ecosystem. So we've seen some real adaptations in terms of our existing work and new work that we've all got onto. I thought when COVID started, my job might just relax a little bit when I got locked up in my house, but it didn't. It increased, and we have COVID research alongside other research, which is good in terms of research, although we preferred not to have COVID around at all. I've been impressed how well our PhD students and early career researchers have adapted the research, as I said, and really seized the moment. And it's, you know, I've had my own students, such a pressure for students who start on one journey and end up on a completely different one. But that can also be exciting as well. We have seen that our researchers use a variety of methods, different methods and measures, and a lot of that's been around looking at experience of healthcare during the COVID-19 pandemic. So I think we've seen that across the presentations today. In terms of where we started, if we go back to what was 7 o'clock in WA, Kathy's research in aged care, this is really important work. And I think one thing for me that the pandemic has demonstrated was our failure to look after our ageing population, especially those in residential settings. But the things that I thought were what I didn't realise, I suppose, until I'd heard Kathy's presentation, was that the system was failing already, and the pandemic just really brought that to the fore. Problems included the funding structures and the impacts of private markets. And I think societies across the world have got to think about the public and private and how we do support systems to be as effective as possible. There were some stark figures in relation to the impacts of COVID across the sector in Australia, with 76% of all COVID deaths in aged care residential settings. That's just shocking. So I took that as a statistic home with me today. The theme of telehealth is a key importance that came through even in the sessions that weren't really about telehealth for me. That telehealth kept having a show, didn't it, across the morning, afternoon or evening, I think, if you're in New Zealand. In New Zealand, we had Jackie's great presentation around the importance and transition to telehealth, but it did feel like you maybe have gone back to business as usual a little bit in terms of the face-to-face, and I think we're seeing the same in Australia in some settings. We had mixed views on telehealth implementation from our clinicians and our consumers. We had Kate, who noted that patients and clinicians preferred a sort of mixed method model, so with some telehealth when it's relevant, but also did enjoy or feel the need for face-to-face presentations, consultations. 80% of clinicians worried about quality consults. Thought that was really interesting, and I think there's lots of research there going forward to unpick what it is around quality that really is a worry to our clinicians. And I shrugged my shoulders, and I wish that Telstra and NBN were on the presentation today, given that we've still got issues around internet connectivity, given the century that we're in. And that's not just in rural and remote settings, it would seem. That's also within some of our metro and more urban regions. And then Andrew's focus on some really interesting work that can be done with general practice data that's beyond MBS and PBS data, and how important that is for us in terms of potentially getting near to real-time information that can be used for planning and clinical decision making. And then we went on to the DCE and preference studies world, which I always really enjoy. It's so great to really get a handle on what it is that both clinicians, policy makers, and our consumers are thinking, and what's driving their preferences. Some of the highlights to me, and I'll not carry on too long because I want to hear from colleagues as well, But I really was taken with some of the home-based care in the middle of the pandemic, and the preferences being displayed there from the clinicians and the parents, who really embraced some of the telehealth and that transition out. And there was a great line from Catherine that said that really, sorry, from Lisa, that said that, you know, parents actually did know what to do, that, you know, they had strong preferences to stay home with their children, and actually did access good knowledge and had good information about COVID and the risk for the children. And I think sometimes we underestimate the power of the consumer and the power of those that are caring for people with illness, and I think that was demonstrated in some of the preference elicitation work. And then we finally got onto the models of care and genomics. And again, I had some great learning points. I always like the fact that I take new information. I learn great things when I listen to the work across the two countries. Caroline talked a little bit around the COVID challenge in cancer service, and that had meant delays in care, and these are likely to impact on services going forward. And this got picked up again by other presenters. So we've got more work to do in understanding that. So what are the impacts in the changed behaviour of people not presenting with non-COVID related conditions? What are the impacts downstream of that? So, or upstream of that. So I think it's really important that we consider that going forward. And like others, Caroline noted the challenges around education, training, and IT and infrastructure. I think the education and training is a really important one for us to continue with in terms of the research that we do. What else have I got on my, oh yeah, Rebecca Jessup. I love Rebecca's top 3 sources of information: television, internet, and family. And all of those worry me in lots of ways. And it just shows that, you know, what we get fed from all of those places really does impact on our thinking and our viewpoints. And that there's difference between ethnicity and culture in terms of what you may access for social media, which again, you know, we only sometimes get with all the great algorithms and machine learning that sits behind social media platforms. We only get certain levels of information from those places. So I think that's a challenge for our health system. And then other things that I think really took home for me were around, it was Mary's presentation around the audits and sort of work that we do. And I like Megan's response back to that around, we've got all this work that we don't publish that's really important, but we just don't get that message out. We're time poor often is one reason, but also that we just don't think it's relevant to be published, or the publishing. I've got a number of studies that have shown that things aren't that exciting, but that's, you know, that nothing really changes, but that's actually important, or that something's failed to work, but no one wants to seem to publish that type of work. So I'll pause there for a second, and I'm going to start. I'm going to have a look. I've got the great thing of looking at all the faces and deciding which one I go to first. And Rachel's took a mic off, so she's keen. So I'm going to go to Rachel and give everyone else a second, just to get your takeouts for today, and what really took, you know, struck you, and what you'll take home.
Yeah, thanks, Suzanne. Terrific presentations. One thing that I'd like to see, I guess, more of is I think there's a huge benefit with the discrete choice methodology in terms of quantifying preferences of the community, of patients, of clinicians. But what I don't see a lot of is the take-up of those findings, of those preferences into policy. And I think, you know, a classic example might be how we roll out a vaccine in Australia. And there's been some excellent collaborative work internationally and across Australia about the preferences for groups of people. And to me, that would seem that is, you know, one excellent example of collecting preferences, and then that information is either not in a format that policymakers understand, or is not that it's ignored, but it doesn't really seem to get traction. So one thing I would love to see, and you know, perhaps there's a way forward here, is to improve the policy traction of discrete choice studies. It's more a comment, Suzanne, than anything else.
That's good. I think on that as well, Rachel, in terms of the work that's been done around COVID, I think that's a real opportunity to do that. It's, you know, when there's a window of opportunity arises with the policy world, then we just have to step in there sometimes. So I'd really encourage our research community to step in to try and influence both federal and state policy. And as you say, I think how we present is important. So maybe we should look to our other successful groups who advocate to government present the information, sometimes very complex information, to those groups. Megan, you've taken the mic, so I don't even need to find people. There's some really there's a real group of enthusiasts wanting to comment, so I'll just go to you for a second. Get your take.
I was just going to back up what Rachel said. One of the big takeaways for me from this, from all of the talks, was that we were asking patients what they wanted. We were asking people for their preferences. How have you found things around COVID? How did it suit you? How are you going to take this forward? And yeah, I agree with Rachel wholeheartedly that now we need to get the government to hear those patients. So the next question for us is, how do we do that? I'd like to think that HSRAANZ could potentially play a role in some of that advocacy. So I would encourage you out there as researchers, if you have those sorts of outputs and you think it can have really strong ways of influencing policy, or that it should, your research should be influencing policy, and you don't know how to take that next step, get in touch with the association and we can help light that way for you and help you with those pathways.
Thanks. I think that's a really good thing for all these presentations for in terms of the work and influencing, that the association will be really keen to support our community to really lobby government with some of the research that we do, and to help them to think that it's important to the policies going forward. Thanks, Megan. Laura, you're next on my screen. So sorry you didn't take your mic off, but I'm going to force that, I feel. So what are your takeouts? What's the takeouts that you've got from across the two countries?
Well, I guess probably what I was thinking the most about is just across all of the studies, and the inclusion of the patient perspective was, you know, the rapid response of COVID. Sometimes we don't get the hard to reach, most marginalized groups represented, because for the reason that it actually takes a lot more time to actually get those perspectives. So I guess that was something that I've just been thinking about the whole morning and afternoon is the question of inequities, and how our response can maybe make some of those corrections. And I was thinking in particular just learning more about discrete choice analysis, and or in our decision making or rationing, where does equity factor in? So, you know, people who are already marginalized from the system, how do our responses, or can our responses make corrections for that in terms of priorities?
I think the equities are massive, isn't it, in terms of research? And I like the point that you raised there, and it was raised, I think, in Rebecca's, in terms of how long one of the interviews or the interviews were taking. And that's just an interview, but there's also the ethics processes and other things that could really hold up the research and put researchers off and put the community off. But really, they're the most important groups that we should be accessing for research. So completely agree that they with the equity, and we did see some of that coming through. Thanks, Laura. I'll continue down, and I'm going to go to our amazing bell ringer, Tilly, and just ask her what her takeouts for today were.
Thanks, Suzanne. You know, I'm located in a regional area, and we really weren't affected by the pandemic very much at all. We didn't have any community transmission. So our research wasn't focused on the COVID pandemic, but our health service was. And what I heard from today was that, you know, the health services rapidly adapted to the change in what they needed to do to be able to continue delivering those services. But also what I noticed, and this was locally as well, and this is an area where we use a lot of telehealth because we have a lot of rural and remote patients. The patients were willing to adapt to it as well. They adopted those changes quite quickly, and we now run out telehealth locally. So for me, you know, that was a great, you know, bipartisan agreement, and it was reflected in a lot of the talks today. The other thing that I really liked about the presentations today was that it wasn't just the clinical changes and the clinical, you know, presentations that we saw. There was a lot of social care, And for, you know, for us in Allied Health land, that's really, really important. So it's been a really good day.
Thanks, Tilly. I agree. I mean, the whole allied health and the broader social services, not just the clinical and health services, are really important. And I think that some of that came through. And we do good work in that. It's just sometimes harder to get that work published and out there than it is to get some of the medical research. So great. And I'm in WA, so it wasn't just the country regions that didn't have much in terms of the research, which is a privilege, but the health system was still very stressed by what was going on or perceived to be coming. Catherine, you're next on my screen. Obviously, you all don't know where you are on my screen, but Catherine, you're next, and over to you to hear your highlights.
Thanks, Suzanne. I think the things that really came through to me today is, as rough as this year has been for everybody, and as challenged as we have all been, I feel like COVID, I've sort of come out of the morning thinking, well, you know, COVID in some ways has given us some gifts, and there were three things that really came out to me today in terms of opportunities that have come through the events of the year. The first is that this pandemic has highlighted gaps in our health systems. So particularly in things like aged care, barriers to the uptake of telehealth, even things like social isolation, things that have existed all along, but it has really, the pandemic has given the opportunity to shine a spotlight on these things and their consequences. And that's an opportunity to start addressing them. Secondly, I think it's provided us some opportunities to learn about ourselves and what we value. And that was really interesting in this series of presentations around discrete choice experiments, whether it was around, you know, who gets the last bed in ICU, or, you know, what were the other ones? You know, what sorts of things do we value in terms of, you know, our freedom versus, you know, how we think the government money should be spent and so forth. And what sort of healthcare systems do we want? You know, so it's given us a chance to ask some of these questions that we may not have otherwise asked. And the third one is that it's really provided us with some opportunities to innovate, which is, if it's that more and better telehealth, is it about different models of care, more use of hospital in the home, ways to prevent ED admissions, different ways to manage wait lists and to, you know, shine a spotlight on those problems. So, you know, I think, you know, despite all the challenges of the year, I think, you know, if we can come out of all this, you know, with some of these insights and a whole lot of fantastic research questions to take into the future, you know, I don't think that the year isn't a total waste. I flipped my calendar at work yesterday from March to December, having not been in the office very much. And I think, where did all those months go? But look, I think, you know, from today we can see that we've actually got a lot of benefit out of them, despite all the challenges.
Thanks, Catherine. A glass half full, which is always a wonderful end to a very difficult year. We're just going to steal a little bit of time and just go to Vanessa so that everyone's had a chance to have the say. So Vanessa, if you'd just like to give us your highlights of the day, that would be excellent. Thanks.
Thank you so much. Well, I think it started on a high from Kathy's talk, and I kept on thinking throughout the day just about exactly what Kathy had talked about in Australia, that it's just as applicable in New Zealand, where we spend so much money from the public health system, and that money is in private businesses such as general practices. And I guess what happens when a pandemic or other emergency exposes the market failure, but that's something that is exposes problems that have been going there for a long time, and the accountability that we can maintain from our public expenditure. The other thing that I was struck by, from a quality improvement perspective, the fact that how hard it is to make change generally, and I guess the adaptability of the health system, practitioners, consumers, managers, researchers in that context. And I guess it's just about how do we maintain that adaptability and flexibility when it's not a pandemic, because we have so many changes that we need to make. Thank you.
Thanks, that's great. What you're saying there is, let's not go back to business as usual. Let's take some of this learnings and move forward. So thank you for that, Vanessa. I'm going to hand over to Rachel now. It's come to the end of the presentations and the formal session now. I'm going to hand over to Rachel, who he's going to do the wonderful thing of giving our awards. Over to Rachel.
Thanks so much, Suzanne. That was a wonderful wrap up. We did have a quick request from Kathy Egar, who's now just joined the panel. We might take a minute. Kathy, if you'd like to respond to anything that's been raised in the discussion, we've probably got about 2 to 2.5 minutes maximum. Sorry, I can't hear you, Kathy. No, your sound is not coming through for some reason. I don't know why. I can see that you're not muted.
Can you hear it now?
Got you. Thank you.
I don't know what's happened. I've got a new computer and it's got a mind of its own. Sorry, I have actually been listening quietly. I guess the question I've got, particularly for early career researchers, is about the role of discrete choices and, in fact, consumer choices, because I would hate to see a health system designed solely on the basis of consumer choice. And I think we've actually got to stay. What is that? What we know about that is that the articulate middle class will do best and all those sorts of things. So I think there is a role for discrete choice, but I think we've got to be really discerning about when we use it. And if I go back to the work in aged care, one of the things that happened in aged care was that a lot of people were left in their aged care home with the providers saying, oh, no, they didn't want to go to hospital. And in doing so, that justified delivering very inadequate care to those people and also putting at risk other people in the aged care homes. And that was particularly the case at Newmarch in New South Wales, but also in some of the Victorian. So I guess my final comment is, I actually understand discrete choice, but I do think we need a lot of policy debate, particularly in the research community, about the value of discrete choice and about the trade-offs that are involved in that and about the other factors, because I would hate to see politicians just going back to saying we can design the health system and make political pork barrelling based on what people tell us they want. So
Terrific.
Sorry, that was
Thank you, Kathy. That's an important observation, and I think it goes to the point of ensuring that the redesign of any health system needs to include preferences from all stakeholders, not just consumers or recipients of that care, as you say. Terrific, thank you.